Hello and welcome to Approaches to Medicine. Today is a beautifully hot summer day in the city of Toronto, and we're going to be talking today about hyperkalemia. So, just a little bit of a disclaimer, you can pause and check that out if you like, but I won't be spending too much time on that. Moving on. Hyperkalemia. What is hyperkalemia? Well, by definition, hyperkalemia is a potassium level greater than 5.0 milliequivalents per liter. Now this may vary very slightly depending on the lab, but this is the standard. Now moving on. Actually, yeah, just as a note to remind you all, don't take any notes, just sit back and listen. I'll be attaching a PDF file with all of these written notes in it, so you can just sit back and enjoy. I figure you learn better that way as well. So, pathogenesis of hyperkalemia. There are four main causes. There is factitious hyperkalemia. There's an increased intake. Decreased output. And hyperkalemia due to release by cells. So if you know, most of our potassium is stored inside cells, something like 98% or more of our body's potassium stores is actually intracellular. So release by cells is can be a major cause of hyperkalemia. Looking at factitious hyperkalemia, this can be caused by a number of things. Anything ranging from hemolysis of the sample. So again, this is more like release by cells, but this is also it can be high up on the list, so something to be aware of, and it causes a fictitious hyperkalemia, and that's not a genuine hyperkalemia. So say someone took the blood sample and damaged it in some way, causing hemolysis, you would have a hyperkalemia. You have prolonged tourniquet use. And other causes such as leukocytosis and thrombocytosis. They're pretty rare, and so I'm not even going to worry about them too much. Another cause of hyperkalemia, increased intake, is diet. IV KCl, so if you're giving too much potassium. And of course, potassium chloride tablets, which may be used by some people as salt replacement, can also cause hyperkalemia due to increased intake. Now looking at decreased output. There are two main causes of decreased output hyperkalemia. We have the first cause being decreased GFR. If your kidney is filtering less, it's able to filter less of the potassium out. This can be caused by things like, it can be secondary to renal failure. It can be due to CHF. And also due to NSAIDs, especially if NSAIDs are given in the context of renal insufficiency. Another cause of decreased output of potassium are things that cause hypoaldosteronism. And this can be divided into three main causes of hypoaldosteronism. And those are decreased renin. So renin is a stimulant for aldosterone production. If you have decreased renin, you'll naturally have decreased aldosterone. And of course, decreased renin can be caused by things such as diabetes and again NSAIDs. Another cause is normal renin. So you can have hypoaldosteronism in the context of normal renin secretion. And this can be due to adrenal insufficiency. So here you have renin secretion, but your adrenal glands are not responding to it. So the aldosterone is not being produced. So for example, Addison's, etc. Of course, you can have normal renin, but if you are on ACE inhibitors, ARBs, heparin, and other such drugs, you're not producing. You're suppressing your aldosterone production, or you're suppressing the effectiveness of the aldosterone production. And lastly, you have aldosterone resistance. And this can be in the context of potassium-sparing diuretic. So things like spironolactone, triamterene, amiloride. And of course, drugs mimicking potassium-sparing diuretics. So these are things such as trimethoprim, which actually mimic, trimethoprim being an antibiotic, which actually mimic your aldosterone production. I don't know if you can hear that, it's an ice cream truck going in the background right now. Okay, now release by cells. Acidosis is a great cause of potassium release by cells, essentially to maintain electron neutrality in the serum and to buffer the acidosis, cells secrete their potassium and intake hydrogen ions, resulting in hyperkalemia. Tumor lysis syndrome, often due to treatment of tumors. When the tumors die, the cells release their potassium stores. Exercise, decreased insulin, and many other such causes, even tissue injury being on the list. So I spent a fair bit of time on pathogenesis here, and again going back, there are four main causes: fictitious, increase intake, decrease output, and release by cells. Decreased output having further subdivided into decreased GFR and hypoaldosteronism, each of which can also have many causes. Moving on, looking at the clinical presentation of hyperkalemia. Now, the symptoms are mostly muscular, and they are mostly due to the conduction of because the hyperkalemia is affecting the ion gradients that exist across the membranes. You're actually having muscular symptoms. These include muscle weakness, stiffness, and this is usually ascending. Don't know exactly why that is. I don't think that mechanism is known why it is. And if it's very severe, it may actually result in flaccid paralysis. Quite dangerous condition. Another muscular manifestation of hyperkalemia is cardiac conduction abnormalities. And this can result in second to third degree heart blocks, ventricular arrhythmias, and even asystole. So something definitely to be aware of. What happens is that when you have hyperkalemia, you actually initially increase muscle excitability. And if you look back at the Nernst equation, you'll see that the depolarization threshold is actually lowered when there's higher potassium in the serum. After this initial increase in the muscle excitability, what happens is that you actually have a deactivation of the sodium channels. And this deactivation of sodium channels basically decreases membrane excitability, and therefore you get all these symptoms such as stiffness and weakness. Then this occurs in the cardiac system. So you can see this is the mechanism behind these two symptoms. And when this occurs in the cardiac symptoms, it's actually quite dangerous. And that's why we give calcium gluconate to actually protect against the sodium channel deactivation that's happening. The exact mechanism by which calcium gluconate works is unknown. Other symptoms rarer symptoms include paresthesias and areflexia. And if it's bad enough, the patient may also get hypoventilation again, but that's quite rare. Moving on to labs. So let's use a green color for that, just for kicks. So labs, when you get a sample back and the blood work shows that the person has hyperkalemia, first thing you want to do is you want to make sure the sample is not hemolyzed. Second thing you want to do is you want to retake that blood sample, and you want to repeat it without a tourniquet. Okay. Then you want to check their GFR. And I just want to give a little bit of a note here, in that if the person has hyperkalemia and is symptomatic, you go straight to treatment. So for example, you have a patient coming in with renal failure who's in a near-death condition, has EKG changes that are suggestive of hyperkalemia. You don't wait to redo the blood work. You go straight to treatment. And we'll get that to a little later. But I'm talking about something like a person presenting with a 5.5 asymptomatic. What do? Well, this is the steps you want to take. You want to make sure it's not hemolyzed. You want to repeat it with a tourniquet, and you want to check the GFR. And after you check the GFR, we're going to go into a little more detail into that in the next video. So we'll just be putting this to a stop.